lecture number 13, Ready for Change, woohoo! A couple of program notes. Get my little pointer here. Still waiting, no baby. Dr. Baum is ready to deliver, so I'll let you all know when the baby comes out. We do know it's a boy, so stay tuned. And for those who might not know, Dr. Rob McElroy will be taking her place while she's on maternity leave, and he's just fabulous. He's already booking out, so if you want to schedule with him, just call my office. He'll kind of pick up the reins where she left off. And lastly, in case you're wondering, we have a fabulous recipe book from our potluck party with all of your great recipes combined, and you're welcome to buy a copy. It makes a great holiday gift, and I didn't really know ahead of time, but look at that red and green cover. Isn't that great? So I'm going to switch shows, and Dr. Gordon Irving comes to us from Swedish Medical Center, where he's the director of the Pain and Headache Clinic. It's been there for a long time, as far as I know, and is just a fabulous colleague who works with a lot of people there and has many different hats. Just found out he's more than a marathon runner. He's, I don't know what you call it.
Stupid.
Not a stupid thumb. He can tell you that story. But at any rate, we're going to switch over. He's going to give us a great talk on pain.
Okay. Thank you. So, yes, I'm not American. I originated in the UK, 19 years in South Africa, 5 years in Houston, which accounts for the deep southern drawl, and now 15 years here in Seattle, which is wonderful. So I've been obviously interested in chronic pain. I've been in chronic pain, now that's not quite right. I've been looking after patients with chronic pain for about 20 or 30 years now. And I've done sports medicine and various other things, but what's always apparent is that our drugs don't work very well with chronic pain. When you look at all the studies that have been done, even the best studies may get 30 to 50% pain relief in about 30 to 50% of people. And as we went through the narcotic era, more and more narcotics, in fact, seemed to make things worse when you got to about a certain level. So it was very confusing from that point of view. And over the last dozen or so years, we begin to look more at the brain and how the brain changes, how pain affects the brain, and now many things about how diet affects the brain. So I'm going to have a look, and I think Dr. Baumgaertel, in fact, has mentioned some of this in her talk. So that was my original concept of the brain. And that's an MRI of me, in fact, and as you can see, it's fairly small in there and probably getting smaller. We have various ways of imaging. There's anatomical imaging, where you can actually look at the grey matter, and you can look at the different connections. You can do something called chemical imaging, so you can look at where the neurons are firing and what chemicals, the neural chemicals are affected. You can look at pharmacological imaging. You get pretty pictures, and you can look at it like that. That's a normal MRI. Then you can add colors to it and come up with blood flows, so you can see the areas where people are thinking. And you can put 3Ds and do all sorts of fancy cuts on it. So we begin to understand more and more about the brain in the living person. These aren't specimens on the laboratory floor. Well, laboratory table, I suppose. So what I want to do is look at the changes that affect the brain in chronic pain. Look at what eating does on the brain, and maybe how to decrease and reverse those changes. One of the things we're at the moment is not at the stage where we can say, if this part of the brain has shrunk because of chronic pain, if we get the person in some way to grow back that part of the brain, in other words, enlarge the shrunken bit, does that decrease the pain? We think it does. Clinically, we seem to see that, but those studies have not been done. So we're doing a little bit of leap of faith, if you like. They are going to be done, they will be done, but at this moment in time, they're not in my literature anyway. If we think about pain simplistically, we can think that, and you don't need to know these fancy terms, I'm going to be asking you questions afterwards though. You get an impulse coming in. Maybe you've got back pain, maybe you've got foot pain. It comes into the spinal cord, and the spinal cord you then go up to various parts of the brain. Now, although we can image the brain, we can't yet image the spinal cord. So we think we know what's happening in the spinal cord simply from mice and rat models. They are now looking at various fancy tests to try and look at the function in the spinal column, but we do not have that yet. So I'm going to stay away from the spinal column because I'm not sure what's happening. The pain goes out to a place called the thalamus, and then the thalamus sends it to something called the somatosensory cortex, which basically says, ow, my back hurts, or ow, my foot hurts. It tells the brain where your pain is coming from. At the same time, it sends messages to what's called the limbic forebrain, or the emotional centers of the brain. Those to do with anger, fear, anxiety, past behavior, past experiences. And they both light up at the same time. So if we put somebody in one of these MRI machines and we create pain on them by squeezing on their nail bed or whatever, their nail bed area on the brain will light up, and the limbic system, the emotional areas in the brain will light up at the same time. So you can't separate emotionality and physicality as we used to say, oh, grow up, forget about it. It's all in your mind. Well, it is all in the mind, but it's physiologically all in the mind. And so if you bring to the table high anxiety, PTSD, depression, so those areas are already lit up, and now you bring pain, then it's adding fuel to the fire. You can think of it as your brain is on fire, and every little bit can add a little bit more fuel. So now your pain is worse. Is that imagining it? No, it's real pain. And the various tests we can do that show it's real pain. So as you see, we now begin to expand our idea of pain, not just from affecting the foot, but affecting the whole brain. And in chronic pain, probably about 40 to 50% of our patients have some degree of anxiety, depression, PTSD, etc. in the background. And so we have to treat that appropriately. And there's also a descending system as well. But I'm going to ignore these two systems because we're going to concentrate more on the brain. So here's a cross-section of the brain. This is the limbic system that I talked about. Here's a somatosensory cortex that says, ow, my back hurts. And then all these little areas also light up, plus a few more. There are about 16 areas that light up at the same time somatosensory cortex lights up. And that's the place where, if you like, that's a central house where it sends impulses all over the place. We also know that pain is not just brain, it's just our spinal cord, it's to do with the individual. We call this a biosocial model, where we have the biological thing. Yes, your back is hurting because you have a herniated disc, or you have pain in the feet because you have neuropathy there, or whatever it is. Your pain is worse because you don't have any social support, you're miserable, nobody understands you. Psychological, you've got high anxiety, depression, you've been abused in the past, in childhood or elsewhere, and they all go to affect the limbic system as well as the somatosensory cortex. So it's all mixed up. What's also interesting is that some of the studies that have been done looking at what's called grey matter. So grey matter are the neurons, white matter tend to be the nerves. This is a study where they had patients who had low back pain, chronic low back pain. They found that when they looked at the amount of grey matter compared with people of the same age who did not have low back pain, didn't have pain, you had losses in the grey matter in those with back pain, 0.5% a year. But in another way, around about 5.4 decrease over 10 years. And it was reduced in certain areas of the brain. So you can think of chronic low back pain as an additional 10 years of brain atrophy. And that's similar with other problems. Migraines, fibromyalgia, diabetic peripheral neuropathy, they all cause brain changes. So if we said, and if you have chronic pain, you know you're not quite the same as you were before the chronic pain, not quite as sharp. Put it down to the medications, maybe it's not the medication, maybe it's something else going on. And so that begs the question, well, can you increase the volume of these areas? And if you do, what's the effect? So far so good, okay? So we said, yeah, pain shrinks the brain. Pain is both physical and emotional, and you can't separate the two. And there are, I think, still a lot of doctors who don't believe either of those facts, but unfortunately they are facts. Now we come to something that I've been interested in for not that long, in fact. Brain changes with eating. We have this classical feature of, we go from chimpanzee to Homo erectus, Homo sapiens, Homo fatuus. And specifically in the Western world, and when people take up Western type diets, which are high in sugar, and in this country very high in fructose. So if you look at obesity, then you have inflammatory cytokines. This is inflammation. These are substances released when you have inflammation. It's increased as you increase your obesity, body mass index. It's associated with a sickness syndrome, which you just feel sick and tired all the time, you just don't feel well, you just don't have any get up and go. And you get inflammatory changes in an area called the hypothalamus, which is one of those areas in the limbic system. So you're seeing changes in the brain where the person who's obese knows they have to lose weight, but they don't have any energy to do it. And part of the reason may be because the obesity is affecting the brain. It also affects other parts of the body, and this brings in something interesting, that if they do skin biopsies in somebody who's obese, it actually looks very similar to somebody who's got diabetes. You start losing epidermal nerve fibers. And we know that obese patients, obesity by itself increases pain. Is it because of the brain? Is it because of the skin? Who knows? We just know it's a fact. And unfortunately, I get patients all the time who say, if I could only have some more narcotics, I could walk more and exercise more and lose weight. Well, exercise, in fact, doesn't lose weight unless you're doing a lot, about 2 hours a day or something silly. As Susan said, that I do these long distance races, so I may be running for 6 to 8 hours. Well, running, hobbling, whatever. And I'm getting rid of about 6,000 calories a day, and I'm taking 2,000 calories a day, and yes, I do lose weight. But do I do that every day? Absolutely not. But it's nice having a few beers afterwards. Trying to put it back on. And these are statistics you probably know. Since the 1970s, obesity in the United States has just climbed 31%. Back in the 70s, now over 111 million. Obesity is BMI more than 30. And if we look at diabetes, it looks the same sort of graph. So there's a strong correlation between obesity and diabetes. There's also a correlation between obesity and high blood pressure, HDL, triglycerides. These are fats you see in the blood. And something called metabolic syndrome, and that's related also closely with cancer, Alzheimer's, diabetes, stroke, and heart disease. And so we've been undergoing an epidemic, and a lot of it is because of the foodstuffs we eat. There's a book called Grain Brain. I think it's a fantastic book. And I'll just sort of highlight a few things from it. So celiac, whoops, let me just go back, sorry. Celiac disease is where you can't take in gluten. And it's not that you can't, if you take bread you don't feel too well. It's actually you get diarrhea and you physically can't absorb gluten. And that's related also to Alzheimer's, cognitive impairment, ataxia, peripheral neuropathy. And so they did a study where they gave some of these patients gluten-free diet, because you do that when they're on celiac disease, and in fact some patients' function and cognitive impairment improved, showing that sort of gluten may have something to do with some of our problems. The average American eats 133 pounds of wheat products, and the gluten now in our wheat is about 40 times higher than a couple of decades ago, due to GMO and due to selective breeding, etc. Now, is that bad? We don't know. You know, I say we're throwing out some facts, but we can't actually link up the dots scientifically. But I certainly get patients, particularly with fibromyalgia, who are gluten sensitive. They don't have gluten enteropathy, they don't have celiac disease, but when they come off wheat, they feel significantly better. So in some patients it's important, in others it probably isn't. I know my wife, if she has even a small piece of bread now, she falls asleep and the next day feels achy. And she loved bread. I mean, it's only the last 10 years she got this sensitivity. What about sugar? I know Dr. Baumgaertel's told you a lot about sugar, and here are some facts. The average American consumes 22 teaspoons of added sugar a day, 77 pounds a year. It's not just empty calories, it's actually toxic. It's highly addictive, it makes one fat, and it saps energy. Is it because of changes in the brain? Well, we'll have a look. And if you look at fat-free foods, and that was interesting. I went on a low-carb diet for a while. I'm still relatively low-carb diet. And looking at fat-free milks have more sugar in than the full cream milk, because they add sugar in order to add body, in order to give you taste. So always look at the number of carbohydrates and you'll be surprised. Yeah, the only problem is fat-free milk froths better for my cappuccino than full. So I've now got a problem. The other problem is that IPA beers are not low carbohydrate. So I'm not very good on my low carbohydrate diet. So this is, again, an interesting study where they gave rats unlimited access to high-calorie food, sausage, cheesecake, chocolates, and they became fat. And every time they went to eat, they basically learned to press a button and the high-calorie food would come out. Then, when they were obese, every time they hit the button, they got a shock. And if they had a button for low-calorie food, they didn't get a shock. So they could choose between a high-calorie and getting a shock, or low-calorie, or normal, your normal chow, and not getting a shock. And what happened? Well, they continued to eat despite the shock. And they were the same experiments were done with rats with cocaine. So sugar is highly addictive. And you know, I talk to patients every day about stopping their sodas or stopping the low sugar, and it's very, very hard. It's like taking away their benzodiazepines, their Xanax, or their morphines, or whatever. It's very, very hard to do. It's a very highly addictive substance. And you have great things, you know, cakes, and you have cookies, and delicious, wonderful. The trouble is when you take them in, you get a rapid output of insulin. That then makes you more hungry, doesn't actually fill you get hungry again, so you take another one and another one. And by increasing the insulin the whole time, you're actually making yourself less susceptible to it. So one of the thoughts about why we have this high diabetic rate is not because we're eating more and exercising less. You know, it's been out there for years, you have to, you know, people are trying to exercise, but they're not losing weight. So part of it is probably because of this sugar, and it's an addictive, and they can't get away from the sugar, because they're now addicts. When they started looking at where the sugar effects, or these high density of food effects, they found that they produce endorphins. Endorphins are basically opiates. The reason why your morphine, your Vicodin works is because you have receptors in the brain. And the receptors aren't there so that manufacturers of morphine could make money, they're there naturally. So those natural receptors for the opioids are filled by neurotransmitters called endorphins. So if you're producing endorphins, as these high calorie foods do, then that's the addictiveness of it. Just like an opioid, just like cocaine. You also get dopamine released when you have these foods. What releases dopamines? Cigarette smoking releases dopamine. Laughter releases dopamine. Seeing a good movie, you know, it's the reward system is dopamine. And these feedback loops spur the patients to seek more and more, and they get tolerance to the effect. Just like you get tolerance to Vicodin or tolerance, and you want more and more to get the same buzz. To get the same reward, you've got to have more. That produces more insulin, and you're on that slippery slope down. You've not realized you're getting addictive, and maybe you become addicted in your childhood. Yeah? You became obese, and it's hard to get over it. You have a sickness response, and then you also get depression. So now you're depressed, and what do you do to relieve the depression? Well, you take something that makes you feel better. What makes you feel better? Well, food makes you feel better. Sugar makes you feel better. Soda, cheesecake. Yeah, you've been very good all day, now you'll just have a cheesecake as a reward. And it is a reward. If you inject morphine into the area of the brain called the striatum, it triggers binge-like overeating in mice. So they just can't stop eating. A bit like some patients, perhaps. It's like me on chips. I can't stop eating those when I take them in. Or ginger biscuits. My wife buys me those triple ginger biscuits from Trader Joe's. I go through the whole box. It's just not fair. I'm totally addicted to that stuff. I never buy them, but my wife does occasionally. So the opioids and the narcotics work on the same pathway as fat and sugar, and they should be thought of in the same way as a drug. If you block the narcotics, we do have drugs which block narcotics. If you do that, you get withdrawal type symptoms in obese mice. So it's as if you stopped their opioids. It's not opioids, it's just they're obese with these high density foods. And it may be some genetic factors. There's a sort of a low dopamine receptor, increased risk of addiction to opioids and to obesity. So we begin to think of obesity as opioids and addiction almost in the same breath. And one of those areas we looked at really early on, which is called the hippocampus, you get atrophy or shrinking directly related to blood levels. So sugar does affect the brain size. It shrinks the brain. This is depression score. This again is the hippocampus and fancy squares and lines. But basically what it says is the longer the days that the patient was untreated for their depression, the smaller the hippocampus. You know, the hippocampus shrinks. So obesity causes depression, and hippocampus shrinking. Obesity causes hippocampus shrinking. Obesity causes depression. What comes first? Yeah, we just don't know. And remember, a lot of these experiments are done in mice and rats, and they're not necessarily the same as human beings. The other thing I find fascinating is that there are taste receptors in the gut. And maybe that's why when you take aspartame or one of these non-calorie sweeteners, it tastes sweet, in the tea or the coffee, but you still crave something because the gut is not fooled. The gut says, yeah, this is not sugar. Yeah, I want something else. These low-calorie sodas have never been shown to decrease weight. You can, or decrease the incidence of obesity or decrease the incidence of diabetes. So there's something wrong about sodas and the aspartame and all the rest of the stuff. So 1 calorie doesn't work, or 0 calories doesn't work. So how do we change the brain? And it's difficult. And what it means is the person has got to get out of the funk. They've got to say, well, a pill isn't going to help me, because most of the pills in pain are narcotic-like, and that just makes things worse. So now what do? So it really is becoming goal-orientated and a lifestyle change. And lifestyle changes are very, very hard to do, without a doubt. This is a picture I like. Here's a universe, and here's a brain cell. Looks pretty similar, doesn't it? It's complicated. This is from Scientific American, and basically this is part of the brain called the hippocampus. And this is a cross-section of it. It changes with sugar, it changes with various states. And this is called a rainbow mouse. And it's called a rainbow mouse because, poor little critter, they've grown this mouse that when you stain the brain with certain colors, new neurons, maturing neurons, and matured neurons, and those brain cells light up different colors. That's why it's called rainbow. So you can see, if you're giving the mouse a difficult thing to do, whether you get more neurons expanding into an area called hippocampus, because you can see changes. You've obviously got to sacrifice the mice, so we haven't done this experiment in humans yet. And I doubt if we'll do it. But what was interesting was these are the stem cells, and even as we get older, we have stem cells. The brain, we used to think that the brain starts dying from the age of 3, and we're losing 1 billion neurons a day, and it all sounded sort of terrible to me. But we know now that even the elderly, i.e. people like me and older, do have stem cells, and they can change the brain. It's called neuroplasticity. So we all have these stem cells which can change and add to volume in the brain. And this is the stem cell, and it starts developing, and you get an immature new neuron, and that'll be a certain color, and then you'll get a functioning full neuron around about day 14 in the mouse. So how do you get these cells to mature? And what they found with the mouse was, if they gave them an easy go, so it's something they could do easily, these cells didn't mature. They just, they sort of got somewhere, and then they, regressed. If they gave them a hard goal, which was difficult to do, the cells actually matured. And they had increased volume in the hippocampus. So if we can make a leap of faith and say, if we, i.e. a human, has a goal which is hard but achievable. I'm not going to go and run 300 miles in 2 days, but I could perhaps run whatever it is in 1 day, and I achieve it. Well, actually, that's a bad experiment. That's because you're going to be dead by that time. You've injured yourself. But if you decide, you're going to start walking maybe 5 minutes twice a day, and then build up to 5 minutes 3 times a day, and so on, and it's hard, and you continue doing it, and you go on your less and less sugar, you go on your low carb diet, whatever it is, that's a hard goal. So achieving the goal, will that cause maturity of those neurons? Will your brain begin to expand? Don't know. Will you feel better? Absolutely. The cause and effect, we don't know. But looking at these sort of mouse modelings, we begin to now to say on a more expected than not basis, this is what may be happening. But again, these are experiments. Just clinically we know it helps. So one of the things that, this is from Journal of Consumer Research, change the way you think about your vices. Even saying something like, I don't eat sugar, instead of I can't eat sugar, changes things. Because I don't empowers the person. I can't means, mummy told me not to do it, I can't do that, but I will do it anyway, sort of thing. It goes back to your childhood. So I don't is very personalised, I can't is somebody else putting it on me type idea. So just changing how you think about things when you're making your goals. The cannabinoids, that's from the marijuana, you've probably heard about that weed. And because when you go on marijuana, of course you don't inhale, you get munchies. You get really hungry. It's like having a few beers, you get really hungry afterwards. And so they said, well, what happens if we block this receptor? And so they produced a drug called rimonabant, which blocks CB1. It decreased the desire for food. It also decreased smoking. People didn't want to smoke. They stopped drinking. They didn't like alcohol, narcotics, cocaine, or other stimulants. So it sounds wonderful. The trouble is it caused severe depression and was suspended in Europe. It's not approved in the US. But these studies are ongoing. In other words, if you can find the receptor that affects things, maybe a pill will help in the future. It's not there at the moment. But it's just fascinating the studies that are going on. Have you heard of the microbiome? So the microbiome is the flora, bacteria in your gut. And you've probably heard if you have something called, C. difficile, where you have diarrhea all the time. They're having these microbiome transplants, where you basically have somebody else's poop put in the bowel, and it's curative. It's incredible, about 90% success rate, something stupid like that. So what they did with this study, they found twins. One was obese and one was slim. They took the gut bacteria from the obese twin and gave it to mice. Now, mice eat crap. They actually will eat their crap in the thing. So they gave it to the mice, and it caused obesity in from the obese twin, it caused obesity in the mouse. And the non-obese twin bacteria had no effect on the mice. They stayed slim. So there's something in the gut of the obese one. Remember, these were twins. They were as close as sort of genetically the same as we can get in humans. Then if they put the slim mouse in the same cage as the fat mice, the obese mice took on the same microbiome, which was stronger, and the mice lost weight. So they became slim. But if you then fed the obese mice a high-calorie diet, they got even more obese. So you can't get over that dietary thing, but certainly the gut bacteria has something to do with it. I don't know if you know anybody who's had gastric bypass surgery, but gastric bypass surgery is they bypass part of the gut, shrink the stomach, so now food goes through faster. You can't absorb it. Well, in fact, the weight loss is so fast. There are changes in the microbiome almost straight away after surgery. And they think that's maybe the reason why you lose so much weight after gastric bypass surgery. So there are lots of experiments going on now. There's some experiments saying, well, what is it? And can we in fact use that? You don't need to do gastric bypass surgery. So again, it's an exciting time. Will it come to fruition? Will anything happen? We don't know. We hope it does, obviously. So we're looking forward to the future where we can all go fast. What about weight? You've heard about this, oh, you've got to exercise. I said, exercise, otherwise you don't lose weight. Well, this was quite a large study. There was 5,000 patients, followed for a period of up to 6 years. And they used various diets, usually low-carb diets. Each has their limitations because you're not allowed IPA beer, or you're not allowed this, that, and the other, whatever it is. It's all difficult to keep on. And in fact, if you're going to do, I don't call it low carbohydrate diet now, I call it a low carbohydrate lifestyle, because it really is a lifestyle. And you lost weight with these diets, but in order to maintain the weight loss, you also had to regular exercise, around about 2,000 calories a week. So round about sort of 2 hours a week, an hour and a half to 2 hours a week of exercise, and you maintain the weight loss. But you needed exercise as well as a sensible diet. Exercise by itself, as I said, unless you're doing a heck of a lot of exercise, you don't lose weight very much. But diet and exercise, you do. So the optimal amount is about 30 minutes, 5 times a week, walking briskly, able to talk but not sing, and 75 minutes of vigorous activity, such as jogging a week, plus 30 minutes of muscle strengthening 2 times a week. So it's actually aerobic plus some sort of weight stuff. And what are the benefits of exercise? Well, it improves your mind, decreases depression and anxiety, as much as or more than most of the drugs out there, in fact. And this is, that really is a validated statement. Assists with organization, planning, attention, protects the body from inflammation. If you do, we did some studies, I did sports science for a while, if you look at people after a marathon, their immune system goes down, and a lot of them get colds and coughs and don't feel well for a while. So really stressing yourself exercise-wise, you can get sick, but doing the exercise we're talking about, where you're sensible, it actually enhances the immune system. Whoops, let's go back. Decreases fatigue, prevents fractures, improves response to insulin. So like the sugar, this one actually improves response to insulin and decreases the risk of diabetes, possibly by something called adiponectin, and lowers the risk of breast, colorectal, and other cancers. So it's not a bad drug when you think about it. It's probably the cheapest drug we have, and probably more effective than most of the drugs out there. But it's not going to be marketed by pharma because they can't patent it. The other thing it does, it increases something called BDNF. It also does nice things to the fat profile, the lipids. But if we look at BDNF, brain-derived neurotrophic factor, here's a hypothesis about part of the reason why your brain shrinks is because of neuronal atrophy or death, because of low or no BDNF. Stress, various other things can affect it. If you, in this case, have an antidepressant, but if you increase BDNF, you can actually get those neurons to mature again. A little bit like that rainbow mouse thing I saw you showed. So if you're going to exercise, you set your goals, a little bit more than you think you can do, but you think you can manage it if you really try. Moderate rather than high intensity. Walking is the easiest to do. If you can do walking, that's great. If not, obviously swimming or cycling if you have some sort of problem with the joints and bones. And they should be realistic and achievable goals. Tai Chi can be done by most people, and you can modify Tai Chi. One of my go-to sites now in chronic pain is a site you've probably heard of called YouTube. And if I'm saying to the patient, go look at Tai Chi, I say, go to YouTube, look at Tai Chi. go to YouTube, look at this exercise for your back. Go to YouTube, look at this. Yeah, they're wonderful. Yeah, there's some rubbish on there as well, but you can usually work through the rubbish fairly quickly. I no longer give YouTube sites very much because they just, a better one comes up. So, Tai Chi is great. This is they did a study, and it was one of the few studies that actually showed increasing volume of the brain in humans. And they did mindfulness meditation. So they took a group of volunteers, and they did it for 8 weeks. These are people without pain. These are normal, non-pain volunteers. And what happened was 8 weeks of mindfulness-based relaxation, mindfulness-based meditation increases the grey matter concentration in the hippocampus, posterior cortex, temporal parietal junction, cerebellum, all areas involved with pain. So will mindfulness decrease pain? Yes, it does. In patients who like doing that. Some patients can't stand it. Some patients get a huge amount of benefit from it. Is that because it grows the brain? Possibly. I think it probably does, but I can't stand up and say here with certainty. It certainly does not harm. And at Swedish, they do an 8-week mindfulness program, for example, which I support strongly. This is an interesting one. Evening primrose oil at 480 milligrams per day in a meta-analysis, which means they had a lot of studies that they looked at, decreased rheumatoid arthritis pain and was useful in preventing weight regain following extensive weight loss. How it works, we don't know. Does it work on the microbiome? We would like to think so, but I don't know. So there are things out there which are everything can be thought of as a drug, but we could think slightly outside the box and get better benefit. So in wrapping up, we went from looking at pain, going up to the brain, where pain is thought of, oh, that's my low back pain, the somatosensory cortex, to the limbic system, and we said we can look at the person's brain. We can't yet look at the spinal cord, so we're not quite sure what's going on there, but we can look at it in mice models. When we look at the brain, we see that the emotional areas of the brain light up with pain. If you light up the somatosensory cortex that says my back hurts or my feet hurt, the thalamus is the main area where it's sent from. So the pain comes up from the feet or the back or wherever. It then goes to the somatosensory cortex, saying my feet or back hurt. It goes to the limbic system. And we know that that limbic system, some of it shrink. And the question is, can we make it bigger? And we've talked about shrinkage in the brain due to sugar, enlargement of the brain due to diet, low gluten, exercise, mindfulness meditation. So hopefully we have some ammunition there to say if we do live a righteous life and do all these things, then our pain can be improved and we can improve quality of life. Thank you.
You're welcome to stay for a little bit. I know there's some people who might have to leave, but if there are any questions, go for it.
Questions? Now remember, I'm what's called an anesthesiologist. In this country we call them anesthesiologists, in the UK we call them anaesthetists, but basically I'm a gas man. So yeah, when I showed you that first slide of my MRI with this small peanut for a brain, remember, if I don't know the answer, I'll lie. If I use big words, I'm lying even more. But you've got somebody there who probably understands when I'm lying. But I'll try and answer questions.
Is there a correlation between inflammation
levels or inflammation markers and weight and fat cells?
Well, the one study showed increased cytokine activity, inflammation markers with obesity. I have not looked at that paper for a long time, and I suspect that you'll find some patients will have low levels, some people with high levels, but general they'll be higher, and there was somewhat of a correlation between, as your weight went up, cytokine, the inflammatory markers increased. So the answer is yes. Does that cause the pain that cause obesity? We don't know. We don't think inflammation in the brain is a good sign. And we think it has marked detrimental effects. And when you look at a normal brain, it doesn't have inflammatory markers or inflammatory signs there. But putting the two together is, we always make these leaps, but scientifically, I'm always giving white lies. Yes, well, this will happen because of this, and if it changes lifestyle, and if there's enough evidence based in there and it's not harmful, I think that's a very valuable tool we have as physicians to be able to change things. So I can't say that if you do mindfulness meditation, you're going to get the brain of Einstein, but we think it'll help, and certainly it helps in chronic pain. So at the Swedish Pain Center, for example, we have people who train patients in biofeedback. We have mindfulness. We have a lecture on neuroplasticity, what happens in the brain when you have pain, and what you can start doing about it, a little bit like I did here. But it's done by a physical therapist, and really saying what they can do. And there's an interesting study where they had patients who had fibromyalgia. Fibromyalgia is all over widespread pain, and we think it's because primarily, well, not entirely, it's a hyperexcitation of the central nervous system. The brain's on fire, so everywhere you touch is painful, and that's fibromyalgia. And they took a group of fibromyalgia patients, as in Scandinavia, and they divided them into two, and randomly one group had a lecture on healthy living, healthy eating, exercise, all the good things in life. And the other members of the group had a lecture on neuroplasticity, a little bit what I gave you tonight, but a bit more detail about changes in the brain and how fibromyalgia may affect the brain and what you can do about it. And that was it. That was the only change in the treatment plan they did. 1 month, no difference between the two groups. 3 months and 6 months, significant improvement in fibromyalgia in those that had the neuroplasticity talk. So just perhaps understanding what is going on, and also validating your pain, because you've got real pain. I can do an MRI, you don't have anything there. It's all in the mind type of thing, and it's rubbish and it never happens. And it's validating, and also it allows them to understand a bit more about what they can start doing in their own mind. The relaxation exercise, the biofeedback type stuff. So we use that, these mind-body techniques, we call them. And we have our own list of books and things. Oh, I meant to bring the stock book. I forgot. If you are online, go to swedish.org /stop, STOMP. STOMP stands for Structure Your Own Management of Pain. What you'll see there is a booklet in PDF form, which I developed with a number of other physicians and psychologists. And it talks about neuroplasticity. It talks about different ways of relaxation, music therapy, hobbies, sleep. And it has hyperlinks to the sites we think are very good about sleep and about exercise and about nutrition. So it's not about come to Swedish and see these wonderful docs. The wonderful docs did the book, but that's beside the point. So if you're interested in a bit more in neuroplasticity, and there's a whole list of books we found useful, and we talked to patients about, you might find this book is useful or this website is useful. And I went through all the websites, and anything where something popped up and said, buy me and you'll get better, that was out. There's some wonderful looking websites out there they spend a lot of money on, but they're usually done by pharma, or somebody wants to sell you some nutraceutical or something. So none of those websites should have that. Some of them are NIH websites because we couldn't find anything better. Because everything else, your depression, if you look up depression, it'll be a pharma website. www.depression, anxiety, it's all that unless you go into NIH. And it's free, by the way, and it's, use it if you wish.
The 8-week course that's
Yeah.
at Swedish, is that primarily for patients who have pain, or can anybody take that course?
Anybody can take that course. It's called Mindfulness Relaxation. If you ring up the Swedish rehabilitation program for physical therapy at Swedish First Hill and just ask them about it. It's a lady called Caroline McManus who runs it. She is wonderful.
And I have brochures in my office too.
Well, there you go. Yeah, so you'll agree it's good. It's a wonderful course.
Well, thank you
Thank
again.